Hi everybody, welcome to your Module 6 lecture on cohort and case control studies. In this lecture we will be accomplishing the following objectives related to case control and cohort studies. So learning how to calculate and interpret key measures, okay? So things like odds ratios and relative risks we've already talked about. We're going to help differentiate between those study designs and identify bias that are inherent to these types of studies. Now, why can't we just do randomized controlled trials all the time? And I've mentioned this over and over. It's really due to the ethical quandaries that can be created through medical research. So essentially, we always try to seek empirical evidence for all the clinical decisions we want to make, but sometimes we have ethical constraints that don't allow us to perform randomized controlled trials. And we see this, for example, with hand washing, right? You would never have a non-hand washing versus hand washing randomized controlled trial because that'd be unethical and gross. And so we need to figure out different ways that will allow us to derive empirical observations, aka evidence, that will drive clinical practice without having to breach this ethical quandary and perform a randomized controlled trial when we shouldn't be. So this is through case control and cohort studies. Now let's start with case control studies. What are they? Basically, they start with the outcome and they go and find the cause. And so other than that, they kind of go the same type of study progress. So you design the study, you identify it, you do the calculations, and you're always assessing for bias. So this is, in a nutshell, how these types of observational studies progress. And in this section, we'll be looking at how they're designed and how to calculate these statistics and assess their bias. Let's look at an historical example of a case control scenario. So this was the Semmelweis observation. So in the 1800s, Dr. Ignaz Semmelweis noticed a striking difference between two obstetric clinics he was in charge of. The clinics staffed by doctors had high mortality rates of 8 to 12% from childbed fever, or basically fever in the mother, while midwife staffed clinics experienced only 2 to 3% mortality, so less than half the rate. So this observation prompted him to say, could hand washing explain the differences here? And so the scientific question was, how do we determine whether hand washing is an exposure that influences mortality rates amongst pregnant women? And this represented a perfect scenario for case control methodology. So what he wanted to do was compare women who died cases with those who survived controls, and to examine the differences, the cause, in the provider's hand washing practices. As always, we must go back to our hierarchy of evidence pyramid, and where do these observational studies fall in? As we can see, they're kind of mid-level. Cohort and case control studies are not the top of the pinnacle, but they're not the bottom either. They're in the middle, so they provide evidence, but with certain limitations. Now, how are case controls set up? So basically, you have to identify the population you're interested in. That can contain both cases and controls. And then you divide your subjects or your participants into case and controls. They're not really participants per se because they're not prospectively participating in your study, but they're participating in a retrospective study. And so you divide them into cases and controls, and then you ask them about their past exposures to see if those frequencies of exposures differentiate the groups. And so case control studies are analytical, retrospective, and quasi-experimental in nature. They're always retrospective, right? Because you have the outcomes first, and you have to go back and find the cause. And so they explore the frequencies of those exposures between the two groups that you have separated. Now let's apply our case control methodology to hand washing, our Dr. Semmelweis example. So the population here in question would be pregnant women at obstetric clinics giving birth. The cases would be those who died during childbirth from a fever, and the controls would be those who survived. And then we would compare and go back in time and assess the frequency of provider hand washing in both groups. So basically, in this case control study of hand washing's effect on maternal mortality, researchers would retrospectively examine the records of those who died versus those who survived for the hand washing habits of those who took care of them. Now, what are some strengths and limitations of case control studies and where they're useful? The strengths certainly are they're efficient for identifying the outcomes, because if you can't identify the outcomes, you can't even start the study. They require fewer subjects than cohort studies, which we'll talk about next. They allow evaluation of multiple exposures, because you can go back in time and pick out as many exposures as you want. They're relatively quick and inexpensive because you don't have to follow them prospectively. And you can establish individual associations, so you have some causal mechanisms underlying there. However, there are limitations, right? They're retrospective. They don't have temporality. You can't really directly calculate incidence or risk. And they're vulnerable to selection bias in the control group, especially because you don't know exactly how to establish who doesn't have the cause, or the result or the outcome you're looking for. Okay? So the ideal applications here of a case control study include rare diseases or outcomes, things that don't happen very often, things that have really long periods of time to develop, maybe cardiovascular disease or potentially even some types of cancers. Ideas are studies where the initial investigation of exposure outcome relationships aren't really feasible in a randomized controlled trial. So starting here with a case control trial is much more feasible than a randomized controlled trial. And so we could think of something like this again could be cardiovascular disease in terms of, do you want to conduct a 5-year cardiovascular disease study right off the bat, or do you want to establish something underlying with a case control study? And finally, whenever prospective studies aren't feasible, you're going to end up in a case control study. In case control studies, we always use an odds ratio, right? Because we are determining the outcome. We're choosing the outcome here is for our patients. So we can't calculate an incidence because you can't do that when you are the one choosing the outcome, patients with the outcome or without the outcome. And so from here, it's just like we learned about, you would develop a 2x2 table. You would do the calculation for odds ratios, and then this compares the odds for exposure in the cases versus controls and allows you to compare the two groups. Let's apply calculating odds ratios to the case control study of Dr. Semmelweis. So in this example, we identified 5,000 women who died following childbirth. You can see that number in the right column of deaths versus 10,000 who didn't. You can see the totals, everything's calculated here. And we figured out how many in each group where the providers washed their hands or didn't, and then filled in the rest of the table. And you can see if we do the calculation A times D over B times C, we get an odds ratio of 0.54. So this value is what we use to determine whether hand washing is associated with maternal mortality. And to interpret that odds ratio, we need to kind of just go back to what it is again. And remember, anything that's a ratio, something that's a fraction with a denominator and a numerator, if it's 1, then they're equal between the groups and there's no effect. If it's greater than 1, the odds of exposure are higher in the cases than controls. So this suggests exposure may be a risk factor that increases the likelihood of the outcome, while odds of exposure are lower in cases of control when the odds ratio is less than 1. So this suggests that the exposure may be protective against the outcome. Applying that to Dr. Semmelweis, the odds ratio is 0.54. So is that higher or lower than 1? It is lower than 1, suggesting a protective effect. And specifically, you can calculate the decreased odds as 1 minus odds ratio times 100 gives us a 46% decreased odds of having a maternal mortality when washing your hands. So the correct interpretation here is there's a 46% decrease in the odds of death in patients being cared for by providers who wash their hands compared to patients who being cared for by providers who do not. And so Dr. Semmelweis, if you'd like to go look up his story, ended up in a mental institution because everybody thought he was crazy, and he died there because of his ideas here. And so you can see he's saying told you so, while being in a mental institution. Now, as we head down the pyramid in study quality, we're obviously going to have common biases that are inherent to a study design like a case control study. So some common biases include selection bias. So How we went about finding the cases versus the control can lead to systematic differences between the groups that lead to bias. Recall bias because it's a retrospective study, and reporting bias because it's a retrospective study. Going back in time, reporting the accuracy between the groups can be difficult at best. And then finally, temporal bias. Because we're going back in time, we can't definitively say whether the exposure preceded the outcome. And with these, you always have to put these into your kind of assessment of any case control study. Let's see an example of where this self-report bias will come into play. So let's give an example of maybe a study where they did self-reported hand washing versus documented hand washing. And so you can see in the observed data for self-reported, the cases were 450 cases in controls, but hand washing was reported as the same in both of them, versus in the actual data, it was much higher in the cases. And you could give a myriad of reasons why people might not want to say they don't wash their hands. It's just like when I ask my kids, did you wash your hands? And the answer is always yes, no matter what, because they know what the right answer is. So that's called self-report bias or recall bias, because it seems they want to avoid any sort of social stigma for not washing their hands. So this is what happens in the one study that has self-reported. There seems like there's no difference, but then there's a huge difference in the actual data when it's not self-reported data or observed data in terms of watching people wash their hands or not. One thing we could do when we have two studies like in the previous slide is quantify that bias and look at the magnitude and direction of it, okay? So bias magnitude measures how the observed association deviates from the true association. And you calculate that as observed minus actual association. So in our example previously, it was 1 minus 0.7 equals 0.83, indicating substantial bias. Okay, that's the magnitude of the bias. You can see that above in the chart. You have a 1 for the observed because of basically recall or self-report bias. And then your actual odds ratio is drastically lower when you wash your hands, and so the actual magnitude of bias was 0.83, which is really quite large. And so then the direction indicates whether the error pulls towards the null, making the association appear weaker, or away from the null, making the association appear stronger. So in this case, the bias was pulled toward the null, right, 1.0, obscuring the protective effect of hand washing. Transitioning over to cohort studies, they're basically the opposite. They're the flipped. You establish a set of patients or a population that have been exposed or unexposed, and then you follow them forward and to see the outcomes. And unlike case control studies, you can actually directly measure incidence and calculate relatively risk, making their results much more interpretable and understandable in terms of clinical use. Okay? Now let's apply that and take a look more in detail. Let's start where kind of this alternative approach came from. So the research question here would be, to overcome recall biases inherent in case control studies, a different approach might involve identifying two hospitals from the early 1900s with contrasting hygiene and policies, one with mandatory hand washing and one prohibiting it, and then follow them forward, okay, and see how many patients die in each group. And so what's the advantage here is basically by structuring the study around the exposure status rather than the outcome, researchers can then establish which one. Temporality, right? The temporal relationship strengthens the causal inference. And so we can say, maybe with a little more confidence, any sort of outcome that shows itself from this data analysis. And although I don't show the pyramid here, case control study is probably on the same par as cohort study, but they're right next to each other, being right below randomized controlled trials in terms of the hierarchy of evidence. Since it's flipped from a case control study, the methodology is pretty much similar, but going in the opposite direction. So first you identify the relevant population, of which has both exposed and unexposed groups. You establish those groups based on exposure. Okay, that's the defining characteristic of cohort studies, and you follow them forward over time until you get the outcome, and then you compare the incidence of the outcome between the groups. So they're prospective, right? Analytical and quasi-experimental in nature. Sometimes they can be retrospective, looking back at existing data. Generally, you see prospective here, but I will make that caveat. It's that sometimes you can have a cohort study that goes back in time as well. Let's apply this methodology to our hand washing example. So here you would identify pregnant women from a source population you're interested in, and then you group them on whether or not their hospital employees wash their hands or not. You'd follow them over time to track mortality, and then you'd compare the incidence between the groups. As with case control studies, cohorts are going to have some limitations inherent to them because they're not the gold standard. But they also have strengths and they have ideal uses. So some strengths here is that, again, we get that temporality back when we're looking at the exposure before the control or the outcome. Okay, we can directly calculate some of the statistics we're interested in, like incidence and relative risk, rather than having to do the odds ratio calculation for case control studies. We can look at multiple outcomes from a single exposure, and they're pretty good for looking at rare exposures because you get to pick those ahead of time. Okay, you don't have to hope that someone gets exposed. And they're less susceptible to recall bias because you're establishing that all up front. You're not asking someone about their exposures in the past. They're only in the group if they have a certain exposure. So limitations is that they can be inefficient for studying rare outcomes because it might take a long time for that outcome to occur. So that's expensive and probably inefficient to do. You typically require pretty large sample sizes, and they can be expensive and time consuming. And they're still vulnerable to selection bias and especially follow-up loss for prospective studies, so attrition. And they're not randomized, as with case control studies. But they're ideal, again, for more rare exposures, investigating multiple outcomes, for giving a temporal sequence when that is especially important, and when direct risk calculations are needed. Now, how do we calculate relative risk in cohort studies? It's just like the 2x2 tables we learned a few lectures ago. Basically, you set up that 2x2 table with hand washing, no hand washing, death, and survival as the outcomes. And then you do the calculation there. In our example here, the incidence of the hand washing group would be 200 over 750 because there's 200 deaths and a total of 750 that wash their hands, so 27%. And the non-hand washing groups would be 100 over that 250, 40%. And therefore, you take those two statistics and divide them. 0.27 divided by 0.4 to get 0.68. And this value is what we use to interpret the results from the study. And as always, because we have divided something by something else, we've created a fraction, something that has a numerator and denominator. When it is equal to 1, there is no difference in a relative risk. When the relative risk is greater than 1, as you kind of can expect, the risk of the outcome is higher in the exposed group. Okay? Versus when the relative risk is less than 1, the risk of the outcome is lower in the unexposed group. So only when the relative risk is equal to 1 is there no association. Otherwise, you can have an increased relative risk or a decreased relative risk. Applying this to our hand washing example, remember our relative risk calculated was 0.68. And so we would interpret that as 1 minus relative risk times 100. It's a 32% decreased risk of death in the hand washing group. Since it's less than 1, it's a protective effect, right? Even though it's a relative risk, it's a lower risk when you wash your hands. You see all the calculations there. If you want to do an interpretation statement, there is a 32% decrease in the risk of death in patients being cared for by providers who wash their hands compared to patients being cared for by providers who do not wash their hands. And you can see that 32% risk of death in the picture on the right. Great. As with case control studies, you're going to have some common biases in cohort studies as well. One would be exposure to selection bias, meaning there's systematic differences between the exposure groups. Okay? Basically, it goes beyond the group of interest. There's something underlying that the groups are exposed to that's different, and you didn't account for that. One big one that's specific to cohort studies that are prospective in nature is loss to follow-up. So when you have loss to follow-up, you don't really know what's happening with that data, and it can certainly cause bias in the outcome measurements. Detection bias, when we might have the ability to, if we don't have a good outcome, detect the outcome between the groups, then we might have detection bias. So if there's differences in how you are able to assess it, have access to charts, whatever it may be. However you're trying to follow up, detection bias can occur, and that can be also kind of a secondary effect of attrition bias. And finally, on confounding, just like as we learned with randomized controlled trials, if there's differences between the exposed and the unexposed groups at baseline, this certainly could be confounding the relationship you later report in your results. Bringing it all together side by side, you can see the advantages of cohort versus case controls. Again, cohorts get to directly determine those estimates. They're good for rare exposures, and you get that temporal sequence back, versus case control advantages are probably less expensive. They're good for rare outcomes, and they require fewer subjects, and they're shorter in duration because they're retrospective in nature. And as we wrap up this lecture, some key concepts and takeaways I want you to know is, what are the difference between them? How do we measure within them and report the results of these two types of studies and the differences and the biases in them? And so I want you to be able to apply those ideas and those abilities to analyze these types of studies to future studies we're going to look at in this class.